Hi everyone, welcome back to our journal club. This is our 7th journal club, and I'm just waiting for Dr. Messamore to join us. He's presenting our article tonight, and it is titled Schizophrenia, an Integrated Socio-Developmental Cognitive Model, which I think is a really cool topic. Let me make sure that he can get on. And hi, Roxana, how are you? I just wanted, okay, we're going to add him. Just wanted to remind you guys, I am using one word to make it easier to find the articles here. Find it. Oh, hi, Eric. You know, got my earphone. I'll be right back. Sorry, guys. Hi. You guys, it's like, oh, I'm gonna wait.
Working.
I put mine in. Well, I'm echoing. No, we're here. One minute, guys. Hi, Eric. Can you hear me?
Okay.
Can you hear me okay?
Yeah, I can hear you fine. Sorry about that.
Oh, there we go. No, you know what? That was my fault, you guys. This was like amateur hour for a second, as if I haven't done these before. But we have to wear earphones now to prevent echoing, which we didn't used to have to, but there we are. So I was just telling everybody that you were presenting our schizophrenia topic. Can you hear me?
There, okay. Yeah, for some reason it went away, but now I can hear you again.
Okay. Hi, everybody. Thanks for your patience. We are live with Dr. Eric Messamore. Hopefully, just let me know if there's any audio problems. I think we just fixed them. So we both emergently just ran and got our earbuds and earphones. Okay, so for those of you who missed last week's journal club with Dr. Messamore, he presented another topic on schizophrenia medications or psychosis medications. And so for those of you who did miss that, I'm going to just let you know a little bit about him. Dr. Messamore, MD, PhD, earned his PhD in pharmacology from Southern Illinois University in Springfield, Illinois. He did his postdoctoral research fellowship at the Karolinska Institute in Stockholm, went to medical school at the University of Illinois in Chicago, and then did his psychiatry residency at Oregon Health and Science University in Portland. He's currently an associate professor of psychiatry at Northeast Ohio Medical University near Cleveland and serves as the medical director of the university's Best Practices in Schizophrenia Treatment Center. He does research about the skin flush response to niacin, which is abnormal in schizophrenia and may serve as a useful biomarker for schizophrenia genetics or possibly as a tool in personalized medicine approach to treatment. He says that he became a psychiatrist partly because it's a natural fit for someone with a PhD in neuropharmacology, but mostly because he likes seeing people get better, and opportunities in psychiatry to help people get better are numerous, and the magnitude of those improvements can be substantial. He has been a member of Psychiatry Network since February of 2016 and says that he enjoys learning from the experience of others. And so thank you again for your time. This is the second time you're back with us, and we would love to hear what you have to say tonight.
Yeah, well, it's a pleasure to be back again, and thanks, Christina, for inviting me, and thanks to folks who are watching this. In today's going for 15 minutes of speaking, I'm going to comment on the paper titled Schizophrenia, an integrated socio-developmental cognitive model. Despite this title being a little bit cumbersome and integrated socio-developmental cognitive model not really rolling off the tongue very well, this paper really is quite fun to read. And in summarizing it, I had the opportunity to explain to all of you how schizophrenia works in 15 minutes. And by the way, the author of the paper, first author, Oliver Howes, fabulous author. I've never met the guy, but I love all the papers he writes, and I think following his output is will be extremely helpful for clinicians in the field. So Howes and yeah, go ahead.
Where's he? No, I was going to say, where's he out of? Like
London.
where does he?
I believe.
Okay.
Yeah, King's College London.
Okay, I was just curious since you're a fan.
Yeah. Well, I mean, so Howes has written. Howes is involved in a group at King's College where they're looking at functional imaging of the brain, and when they do functional image, they can tap upon either functional MRI, which will allow you to measure the concentration of chemicals like glutamate in specific brain regions. Functional MRI, I'm sorry, scratch functional MRI. Magnetic resonance spectroscopy is the technique. It allows you to visualize, you can see the brain, but you can actually measure chemical content in it. And then Howes will reference in this paper studies on using positron emission tomography, where they will actually measure the ability of the human brain to synthesize dopamine in vivo. So you can give radio-labeled precursors to dopamine and measure its uptake into the brain and the formation of dopamine. So with this technique, between the two techniques and then using, reviewing the literature, it's possible to come up with fabulously interesting theories about neurochemical subtypes of schizophrenia. Howes and Murray in this paper describe, in fact, using this positron emission tomography dopamine synthesis capacity test, an ability to detect aberrant dopamine synthesis, enhanced dopamine synthesis in individuals, predominantly youthful individuals, who are experiencing prodromal symptoms of schizophrenia. So before the actual establishment of enduring psychosis with these nonspecific prodromal symptoms, it is possible to detect elevated synthetic capacity of dopamine in the striatum. And it turns out that has a very strong predictive ability to know which among the prodromal subset are going to progress to syndromal schizophrenia. Using clinical high-risk criteria, you usually get about 30% predictive ability. So if I do a structured interview and I say, based upon the symptoms of attenuated psychosis or intermittent psychosis or derealization or lower grade psychosis, I only have a 30% ability to know who's going to have schizophrenia in a year. Whereas looking at this technique of dopamine synthetic capacity, you get to 80% likelihood of diagnosis. So really interesting. Okay, enough about Howes and his group. The model that he describes has three principal components. One I've actually touched upon at some length already, dopamine. And anybody who practices in this field knows that schizophrenia is thought to have something to do with dopamine. Another plank of or element in this hypothesis is salience detection. Within the brain, there are circuits, they actually call it the salience network, whose job it is to alert the brain to when it's time to think about something. So broadly speaking, the brain can go into what's called the default mode, in which the monitoring systems of the brain are primarily internally directed. And then in contrast to default mode functioning, you have cognitive executive functioning or central executive functioning, which is externally directed and invokes problem solving and associations with learned experience and so forth. Salience signals switch to processing mode, if you will, from rumination to processing, roughly speaking. And dopamine turns out to be a key signaling molecule in the salience network. So when dopamine is released in ventral striatum, nucleus accumbens, and so forth, that is a signal to, hey, something important happened just now. Let's pay attention to that. So dopamine and salience detection. And finally, the model invokes cognitive processes, or once you get this signal that something is important with, say, this little case, then the brain has to come up with an explanation. Well, some people will call it the mind. Higher processing has to occur in order to account for why is this particular stimulus relevant and how does it fit into a bigger picture. And those three things actually can explain a lot about the phenomenology of schizophrenia. So a bit closer look at dopamine. I think this audience probably doesn't need a whole lot of review, but drugs that cause dopamine to be released can reliably cause something that looks a lot like schizophrenia. And drugs that block dopamine signals have a pretty reliable ability to reduce psychotic symptoms in schizophrenia. Animal studies and other human studies have shown that dopamine is relevant. Salience, to build upon that, the example, let's say, this pen, ordinary thing, sits on the desk. I don't really pay that much attention to it, but just imagine now that this stimulus creates a salient signal because my brain has been primed to release dopamine, to synthesize dopamine, and to release it in excessive quantities. Then I see this, and there's something here. There's a there here. And then okay, so that's salience detection, and then cognition comes into, what is up with this pen? There's something. Why is it that this seems now so special when in the past it seemed so ordinary? And we have to, we are wired for meaning, and you can take that at any number of levels of interpretation, from basic neuropsychology up to spirituality. But I think when I say we're wired for meaning, we have a compelling need to make sense of the world. So everything that we see, we have almost an evolutionary drive to put it into its place so that we can have some reasonable ability to predict the future, particularly to predict danger. It enhances our survival. So when we start getting these irrelevant or excessive salient signals, then it can become very confusing. It's quite common, especially in prodromal states, to hear people say, like, it's just everything seems the same, but just different in some weird way. And certain people's faces or facial expressions, objects and things will have an aura of oddness or unfamiliarity or pregnancy with meaning about them, and so the mind then struggles to make a story out of it. If adverse environmental events in early development have predisposed one to a cognitive scheme whereby people can't be trusted, or bad things are about to happen and so forth, then it's a natural step to get to construct a sort of paranoid or suspicious framework around these unusual events. Concluding that there's something sinister going on, for example, or having any kind of paranoid or psychotic level response to these unusual salient signals creates stress. And in the article, they go on to point out several lines of evidence to say that stress itself sensitizes the dopamine system to be more active. So stress releases dopamine. Dopamine then triggers more irrelevant stimuli. And so then you set up this vicious cycle whereby initial psychotic episodes eventually in a psychosis-prone brain make psychotic experiences more likely to happen. And unfortunately, these processes largely occur in the ventral striatum, and the striatum itself is a region which is involved in automaticity, or the sort of encoding of habits. So then these cognitive processes become, they say hardwired, but they become more easy to elicit. So those are the elements. So that model very easily explains paranoid interpretations and a whole bunch of delusional schemes. I can easily, I think anybody listening can see how, with this variety of random aberrant salient signals, I may conclude people are out to get me, or I may conclude that I have now gotten special messages from God, so I could be either scared or elated. And indeed, you see these different emotional experiences, especially in prodromal states. So the model accounts for that very well. how does it account for hallucinations? In my view, it becomes a bit of a stretch, but within the framework of the model, we are also generating a lot of internal experiences. They call them in the paper percepts. So this would be like sort of thoughts, if you will, that I generate. And salient signaling is involved in assigning external or internal localization to these things. So essentially, excessive dopamine signaling causes people to misread their internal percepts and perceive them as external ones. So in this model, hallucinations would be interpreted roughly as thoughts or ideas which are given an external locus due to misassignment of salience. I actually think that there are better models to explain that, but within this framework, that's how they work. Aberrant salience also accounts reasonably well for cognitive disturbances. So when we learn something, we're actually getting salient signals in the process of learning. I'm expecting to get a right answer, and I see a right answer. Bingo, that's a relevant thing. Or I'm expecting this to happen, and what I expect didn't happen. That's also a salient signal. So if we get these salient signals for associations that are irrelevant, where A is not supposed to follow B, but our mind registers as if it does, you can see that this creates a very strong impediment to learning if we essentially don't have an internal recognition for what is right or correct, logically speaking. And the authors themselves in this paper struggle to fit their model into the understanding of negative symptoms. And I think that the problem with this is that they get hung up on the salience signal. Within the cognitive, they invoke, so to review, they invoke dopamine theory, neurodevelopmental theory, in other words, a brain is predisposed to have these things, and cognitive theories. So it goes from molecules to cognitions, which is one of the fabulous things about this integrated model. So you don't have to look at the molecular explanation. Cognitive theories of schizophrenia actually have very well accounted for, or at least come up with reasonable explanations for negative symptoms specifically. People with schizophrenia, on average, tend to have some cognitive impairments early in life. Not infrequently, they will have social impairments or social difficulties. And so if you take a young person and they're struggling in social relationships or in academics, they will begin to develop a schema that they're going to fail at things, or that the success in these efforts isn't going to materialize. So there's a tendency to become withdrawn. Add on top of this now psychotic experiences where the world becomes very unpredictable in a person with a cognitive schema of the world is unsafe and the safe thing is to withdraw. And then you have a situation in which one who's developed these schema which don't predict success and which drive one to be with self-absorbed or withdrawn in a psychotic state, then one never challenges that. And so then one is left with delusional ideas about self and no underlying cognitive scheme to counteract them. So that's not in the paper, but that's my freehand attempt at explaining how negative symptoms work in a cognitive theory. So then basically to review, dopamine is highly relevant in schizophrenia. Howe and Murray go to great lengths to explain that the defect in dopamine signaling is a presynaptic one. Specifically, there's an ability to synthesize dopamine at significantly higher rates and therefore to release it in greater quantities. So it's a presynaptic problem. They actually show that in first episode or drug naive or patients especially that haven't been exposed to the long-term effects of drugs, that dopamine receptors appear relatively normal in number and density. So it's more of a presynaptic problem, much more of a presynaptic problem than postsynaptic. And a second finding in this is that these presynaptic changes in dopamine synthetic capacity are evident during prodromal states, and they worsen as one moves into full-blown schizophrenia. So it's both the earliest neurochemical deficit and one that grows as one goes further into the illness. And so So you have aberrant salience, and you construct these narratives based on cognitive schema, and that's how you get the basic symptoms of schizophrenia. A highlight of this model is that it is, in contrast to pure interpretation of neurodevelopmental model, you're not doomed from the womb. This is merely a predisposition, but the ultimate kicking over into psychosis is the cognitive interpretation of these unusual salience events. Therefore, it certainly opens up the door to interventions which look at those cognitive processes, and cognitive behavior therapy for psychosis, or a variety of metacognitive psychological therapy strategies are showing themselves to be of great value. So I think that within this model, the way forward is on, one of the ways forward is on remediating those aberrant cognitions. There's also within this model an ability to explain gaps in psychotic experiences, and certainly the role of stress in exacerbating them. So, and further, I think the last thing I would comment about this is that within this model, I think it helps clinicians, and probably more especially their patients, to understand the nature of these highly unusual symptoms. Rather than you have these out of the ordinary beliefs that people are following me, or that I'm having hallucinations, knowing that this is the result of dopamine firing in certain circuits, which makes something seem more important than they really are, can be a stress relieving. I mean, the knowledge itself can relieve stress. It provides a reasonably easy to understand explanation for symptoms which historically have been seen as earth-shaking in their importance and impenetrable to reason to understand. So those are my comments on this paper. We can have discussion or questions around it at this point.
Yeah, no, that was great. Thank you again. And yeah, I love the idea. Well, I love the idea that there's more and more evidence how stress really can affect either decreasing stress, improving things, or worsening stress, worsening things. So, and a lot of medical illnesses too. So not just psychiatric illness, but a lot of medical illness. And I think this just gives us more and more. I mean, at least for those who want additional interventions besides medications, it definitely gives us like something of value to talk about with our patients. So.
Yeah, and in fact, we should be talking about more than medications with our patients with schizophrenia. This is, again, I'm just going to state things that everybody knows, but this is the illness itself. It affects almost every facet of life, and so treatment is focused really narrowly on basically one receptor subtype of one neurotransmitter system. So that's a lot of burden hangs on just that one receptor target. And it's realistic, and it's unrealistic to think that that's going to solve the problem. So one needs especially to look at the cognitive distortions or the cognitive schema, as well as providing simply education around the illness to patient and family. And the data are very clear that the historical orientation of, poor you, we need you to take medicine and disengage from stressful things and go over to this place. That's probably the worst thing that we could have been recommending, because then, as again, we're wired, not only are we wired for meaning, we are wired for connection, and we're wired for purpose. And so, I mean, we have evolutionary drives to be useful to other people and to live in communities in which we are seen as valued. So, as much as we can, we need to get our patients into the world with special attention to making it not a stressful entry, but aiming for resumption of education or resumption of work, or activities which will foster social connections, in addition to helping people manage the stress of the symptoms, and to think about their thinking around their illness. All these things are important. Actually, if we can do this at scale, if as a field and as a network of mental health agencies, if we can get the idea that schizophrenia is a sort of, if you will, a comprehensive illness which requires a comprehensive treatment, I seriously believe that we can we can change the public perception around this illness, and that's
Hmm.
the single most important thing that we can do to reduce stigma around this, is to simply get people better with greater reliability and greater numbers.
You stated that very eloquently, so thank you.
Thank
I
you.
think, yeah, we don't have any questions. As always, you can always post the questions as comments later, and we'll check back. But with that, we will wrap up. I do have the link in the post for how to obtain the CME. It is the updated link. And of course, you can always just, if you're not on our listserv or mailing list, just email me at psychiatrynetwork@gmail.com. That's one word, psychiatrynetwork@gmail.com. And just put subscribe in the subject line, and I will add you. And yeah, we will see you next week. We have 2 new speakers next week on 2 new topics. So our schedule is in the Psychiatry Network Facebook group. So you can just find it there. All right, guys. And thank
All
you
right.
again, Eric.
My pleasure. Feel free to send me questions in the messenger or wherever you like.
Okay.
All right.
All right. Have a good night, guys. Bye.